Hey everyone, welcome. Hi everybody, hope you're having a good day. Welcome, welcome. All right, let's see if everyone is joined. We'll have some folks coming in still. Hi everyone, hope you're having a great week. Hope you had a good weekend. Welcome to session 4 of our Northeast CPI collaborative. We have a lot of great things lined up for today and are looking forward to having a great conversation with you all. Um, so please, update your Zoom name if you've not done so already. And throughout today's session, please feel free to engage in the chat, come off mute, ask questions. We really want to hear from you and want this session to be as helpful as possible. We have an icebreaker question today, which is what TV show are you currently watching? So feel free to pop that in the chat. I know I could use some new TV show recommendations, so looking forward to hearing some of those. So take a minute there to update your name, enter that answer to that chat question. 1923, I haven't seen that yet, Megan, but I've heard very good things. Supernatural, oh, that's fun. Yeah, same, Caitlin. Last of Us. Yeah, I started that one. It was a little stressful and intense for me, but maybe I'll try it again. All right, so keep popping those in there. And we can go ahead and move on. So welcome everyone. If you're new to the CPI space, this is really a space for regional CalAIM stakeholders to really come together, collaborate, identify challenges, and problem solve with the goal of improving CalAIM implementation and driving utilization. So we're really happy to have you all here. And please, ask questions, meet each other, network. That's what this space is for. And we're happy to have you here. All right, so today's agenda, we're going to go over some kind of general updates, share some DHCS policy updates. We have a provider spotlight today, which we're really excited about. We have Rebecca from the Canopy Clinic at the Modoc Medical Center, and she's going to share a little bit about the work that they do. And then we're going to have an overview of the Justice Involved initiative, get some updates from Partnership Health Plans specifically related to JI updates, and then we'll move into next steps. We'll talk a little bit about our May session, which will be in person, and then also talk a little bit about other opportunities to connect via office hours and one-on-ones. So our objectives for today are to review important statewide DHCS policy updates and share resources, to engage in a provider spotlight to help identify some best practices and opportunities for coordination, and then to receive a refresher on justice-involved pre-release services, including an overview of the initiative, eligibility criteria, and services offered. So we're going to move right into our updates and resources. Wanted to provide a reminder that the deadline to apply for cited round 4 is May 2nd. So that's coming up. We've shared these links before, but just to remind everyone what resources are available to you in terms of the guidance document, funding request workbook, the application, FAQ. So these are helpful resources if you're in the process of applying, and there are some additional helpful links there as well. And you'll receive this deck as always after the session. Then wanted to provide a quick update about closed loop referrals. Effective July 1st, MCPs will be required to implement the closed loop referral requirements for ECM and community supports. And DHCS released materials from their February 13th webinar to share more details about these requirements. And the DHCS provided the department's goal and motivation for releasing these new closed loop referral requirements, how these requirements will improve the member referral process by streamlining referral tracking, supporting, and monitoring efforts. And then there's an example use case scenario on how these requirements would assist a member in receiving the medically tailored meals community support. But those materials are linked there, as well as some additional information about the requirements as well. So that's all included in that slide. We have a TA Marketplace announcement. In March, DHCS released the PATH TA Marketplace TA Recipient Policy Guide. And this includes information that is helpful for approved TA recipients, including attestations, TA project guidance, how to add delegates, withdrawing projects, progress reporting, and name changes. And there's a link there to the TA Marketplace website, as well as the email to reach out to if you have additional questions. We have one more TA Marketplace update here. There are new on-demand resources available, including Medi-Cal Managed Care 101 for community supports, for ECM benefits, CalAIM 101 training, ECM 101 training, and a CalAIM Navigator video series. We also have some resources linked there specifically for justice-involved populations. There's a reentry toolkit and the billing toolkit, and some additional links for more information. And then we have an update here for child welfare and enhanced care management. For Circle Health Network's latest white paper, at the intersection child welfare and enhanced care management, is a report that offers key recommendations for increasing enhanced care management enrollment among children, youth, and families involved in the child welfare system. The most recent DHCS data highlights a gap in access, with fewer than 1% of Medi-Cal enrolled children using ECM services and less than 4% of eligible foster care youth receiving essential supports as well. So this paper really provides all of that background information, as well as strategies to work on closing these gaps and strengthen support systems for vulnerable children and families. And the full report is linked there. Those are all of our updates for today. And so now I'm going to pass it over to Rebecca Bales from the Canby Family Practice Clinic to share a little bit about the work that they're doing, and to give you all an opportunity to ask questions as well. So Rebecca, I will pass it over to you.
Hi, my name is Rebecca Bales. This is Julie. She's the clinic manager. I'm the ECM lead care coordinator for the Canby Family Practice Clinic. We're a rural clinic and a branch off of Modoc Medical Center. Currently, we're piloting the program for Modoc Medical Center and starting in Canby. We're only accepting Canby Clinic patients currently, and that's kind of what we're doing. So we are currently serving high utilizers, SUD and homeless populations, and mental health and behavioral concerns. As a clinic, we're well positioned to refer patients to mental health services with ease, and that allows us to support those that might otherwise fall through the cracks. Like I mentioned, we're currently piloting the program for the rest of Modoc County, and right now it's just me. Julie is managing, and hopefully by the end of May, we'll have another coordinator to help us out. Our mission is to basically just design a sustainable EMC program for the clinic, for Alturas, for the rest of Modoc County. We're hoping for growth, staff training, and basically to help our rural community thrive and bring resources to Modoc County. So I'm calling this the power of outreaching the right way because that's kind of where we have been shining for the most part. What we're doing is utilizing personalized scripts um, to reach out to members via the phone. So we're saying things like, hey, the reason I'm calling is because we have started a new program here at the clinic for enhanced patient care, and one of our doctors referred you to me and wanted us to reach out to get you enrolled. Um, I mean, we just kind of go on. We make it very simple, very easy to understand. I'd love to set up an appointment with you to have you sign some paperwork for us. If you can't make it to us, we'll come to you. So when conducting outreach by phone, we found that it's most effective to avoid sounding like a shady used car salesman. Our goal isn't to sell the service, but rather to offer it, just like we would an annual checkup to those who are truly in need of the services. So far, this approach has proven successful in reaching individuals through phone outreach, and at this time, we haven't even found it necessary to follow up with in-person outreach as our phone script continues to be highly effective. Another best practice that we have found is we are giving out surveys during enrollment. So when you give out your ROI, you have your patient or the person you're trying to enroll fill out a survey that tells us what they kind of need and if they need anything in particular. We developed a pre-enrollment survey to better understand the needs of our patients before they begin ECM services. It helps us identify priorities and tailor support from the start. The survey sparks meaningful conversations and encourages patients to ask questions and engage. It keeps them coming back. It keeps them, it builds rapport and relationships. As a result, we know exactly where to focus our efforts when building care plans. So far, this has led to about a 97% enrollment rate since the beginning of January. So, like I said, we kind of give it to them from the very beginning. We've developed the survey. The tool helps us identify individual priorities early on. It enables myself to offer tailored support from the very beginning before we even turn in our TARs or anything. The survey not only fosters meaningful conversations and patient engagement, but it builds trust and deeper connections. So yeah, we do have some challenges though, which is on the next slide. So Modoc County is rich in natural beauty and abundant in scenic resources. Despite our breathtaking landscapes, finding essential resources for our community is one of our greatest challenges. Our rural region faces significant barriers that impact access to care and well-being. Transportation, harsh weather, long travel distances make it difficult for patients to attend appointments or get to essential services. And so they kind of fall off the map. They fall through the cracks. Also, if you are also a rural community, you understand there's like technology and broadband gaps that, not everyone is able to even get to telemedicine if their internet connection isn't wonderful. Additionally, compared to other counties, we serve a disproportionately high needs population, with poverty and social isolation significantly impacting health outcomes. So these challenges are pretty, it's difficult, underscoring the importance of flexible and relationship-based models like ECM to meet patients where they are and where they could go. So. We have some goals On the slide I put short-term goals versus long-term goals. We'd like to hire more staff. That's
I'm nodding yes.
yes, yeah. And you know, renovation for the ECM department, because we have this office that's available, but we have a building that's currently being renovated, so we have room to do the things, yeah, room to grow the things that we want to do. We'll be presenting our progress to the board, and we've decided that we'll be offering Sage vouchers, which is our best vouchers for our members to help with transportation. So we have long-term goals as well. ECM program, we'd like to expand it to all of Modoc County, expanding services to the Alturas Clinic, increases our eligibility, population reach, because right now we're only enrolling members for the Canby Clinic, because we wanted to start small. We wanted to build the program. We wanted to know and find out what works before we expand. And that way our resources are used properly. Enhancing outreach efforts and leveraging community referrals. We're deeply working with the marketing coordinator at Modoc Medical Center to expand the ECM awareness to the rest of Modoc County, because as of right now, I think people just don't know what it is. They don't understand what the program is, what we have to offer, what it could do for them. So that's kind of what we're doing. And we just want to integrate the ECM operations into our clinical workflows, and we'd like to do that successfully. So being in the collaborative is cool. It's great because when I first started, we had a whole list of facilities that have ECM and CSM programs, and I reached out to everyone I could to understand and learn, because I feel like this program is still very much in its infancy, even though it's been kind of around for a while. So it's learning from everybody else is the biggest way that I learned and that we learned, was just reaching out and networking to whoever we could find, whoever would talk to us. Hello, can you tell us how to do this? Especially us being a rural community, it's very difficult to network when there's nobody else who does this. So understanding outreach, understanding how to reach out to people, understanding the process on just a deeper level, just knowing how to do things right. So if and when we do get audited, we are prepared for it and prepared to know how to answer questions and the best that we can be. We want to build trust with the ECM program. We'd like to build trust with our patients, but also internally with the rest of Modoc Medical Center. We'd like to build trust for the program. And using the collaborative helps us do that, and just kind of just share what we've learned and share our best practices and what we've faced as our greatest challenges. So thank you very much for listening.
Thank you so much for sharing, Rebecca, and for sharing kind of your journey and resources that you've developed. Are there any questions for Rebecca? All right. Well, I think you shared some of the resources that you developed, so maybe we can share those out with anyone who's interested as
Yeah,
well.
sure. No worries. Thank you very much for your time. We appreciate it.
Yeah, thank you so much. Okay, moving on. We are going to move into our justice involved overview, and I will pass it over to Rebecca Karazi, who will walk us through some information about the JI initiative.
Eva, I really appreciate the opportunity to be here with you all this afternoon to give an overview of the Justice Involved Reentry Initiative. It's an initiative that's been happening for the last couple of years and will continue on. So we want to make sure that you guys have some basic knowledge of what's happening, and also to tee up a conversation we're going to have on Thursday to focus on the care management component of this initiative. So I welcome you to join us for the office hours on Thursday for that. And then we'll likely be continuing the conversation during the in-person next month. So next slide, please. All right, so a couple years back in 2023, California became the first state in the country to offer a set of Medi-Cal services covered by Medicaid dollars for individuals who are incarcerated in certain facilities, correctional facilities in California. This was accomplished through what's known as a Medicaid demonstration waiver, which is the same vehicle that was used to get approval for the CalAIM initiative originally as well. Next slide, please. I think what's often lost when people talk about this initiative is what exactly is happening. What is going to be the impact of this initiative on Medi-Cal? What's going to be the impact on individuals who are on Medi-Cal who are incarcerated in California? So I want to give you two major shifts that are happening as a result of this initiative. The first is that Medi-Cal is effectively expanding to include individuals who are incarcerated in certain facilities in California. It's representing a Medi-Cal expansion that would otherwise, without the approval that California got from the federal government, individuals on Medi-Cal would have their Medi-Cal suspended upon entry into a correctional facility. So this is enabling California to use Medi-Cal dollars to offer Medi-Cal services to individuals who are incarcerated. So that's the first big shift, the Medi-Cal expansion. The second big shift is that in order to provide Medi-Cal services to individuals who are incarcerated, correctional facilities in California are going to become Medi-Cal providers. They're actually going to be able to be in a position not only to sort of meet the obligations as a Medi-Cal provider in terms of services, but to actually get reimbursement for the first time through Medi-Cal for providing those services. So the correctional facilities, through a lot of work and a lot of resources and a lot of infrastructure that's going into place, are getting folded into the public healthcare system here in California. This is a big deal, and it's a tremendous shift from the status quo. So I can't understate how big this is and how much resources going in to make this happen. This is a really, really big shift that's going on. Next slide. So why does this matter from an individual's perspective? Why is the state Department of Healthcare Services, which is overseeing this initiative, why are they focusing so heavily on justice-involved individuals? Well, as it turns out, individuals who are incarcerated in California and across the country have a much higher healthcare need than the general population. We see much higher rates of physical health needs. These are things like diabetes, heart disease, but also a much higher rate of behavioral health needs. Mental health issues and substance use disorders are big issues that we see amongst the population that's getting incarcerated in California. So from a population health perspective, this is a really important population or part of our population, our community in California, that we should focus on from a health improvement perspective. We also know that there are certain groups that are incarcerated far more frequently than other groups in California, and this has especially had a major impact on Black men. Again, here in California, but also across the country. So this is not just a health, concern, but this is an equity issue as well. Next slide. Okay, so this is a very handy image that was developed by the Department of Healthcare Services, or DHCS, to give a sort of summary of what is going into this Justice-Involved Reentry Initiative, or JI initiative, as it's also referred to. And you can see there's a lot of different pieces here. You'll probably notice amongst you all in this group, you'll probably be very familiar with what's happening on the right-hand side of the screen. Enhanced care management and community sports, for example. These are the bread and butter of your groups, what you're working very hard to implement. But what I also want to emphasize in this image is that it's not just ECM and CS that the state is interested in making available to individuals who are incarcerated and formerly incarcerated, but there are a lot of other services and activities that are going on and the state's focusing on for this population of focus. And that largely has to do with what's happening on the pre-release side, or what's happening in correctional facilities throughout California. It begins with providing individuals support to enroll in Medi-Cal upon incarceration if they're coming in not already enrolled. And it involves a whole long list, which I will share shortly, of services that are being provided to individuals during incarceration if they qualify for these services. That also includes this middle piece here on behavioral health links, and that has to do with supporting continuity of care for behavioral health services between when an individual is incarcerated and when they transition back into the community. So next slide, please. Okay, so I've talked about correctional facilities, but I need to be more specific because this initiative only covers specific correctional facilities in California, not all correctional facilities. The ones that are covered, there are 3 types: the state prison system, county adult correctional facilities, which are the county jails overseen by sheriff's offices, and county youth detention facilities. These are overseen by probation departments at the county level. What's the facilities not covered under this initiative? Federal prisons, Department of State hospital facilities, and city jails are not covered. Next slide, please. Okay, so what criteria do individuals need to meet in order to get access to the services that are available under this initiative? So first and foremost, it's almost a prerequisite. Individuals have to be on Medi-Cal. So just like you guys know, in the community, to get access to ECM and CS, individuals have to be on, enrolled with a managed care plan under Medi-Cal, right? So similar here, these individuals have to be enrolled in Medi-Cal to get access to these services. If they are in a youth detention facility, or they're under 21, or they are a former foster youth under 26 years of age, then all they need to meet is to be on Medi-Cal to get access to these services. If an individual is not meeting those criteria as a youth, then they're probably an adult facility and they'll have to meet one of these additional healthcare need criteria on the screen. So they would have to demonstrate mental illness, a substance use disorder, a chronic condition or significant clinical condition, intellectual or developmental disability, traumatic brain injury, have HIV, AIDS, or be pregnant or postpartum. So as I mentioned, there's a much higher healthcare need burden among this population. So the state estimates that about 80% of individuals will meet one of these criteria and be eligible for these services during incarceration. But it won't cover everybody. There will be some people who don't have a tremendous health need who will be incarcerated. So just be aware of that. This is not going to cover everybody. The other thing I want to mention is that the criteria I just went through are the same criteria for the justice-involved population of focus, or individuals transitioning from incarceration, for ECM. So individuals who meet the criteria for pre-release services will automatically qualify for ECM in the community. So that was intentional by the state. Individuals will still need to opt in to ECM just like they do in the community, but they will automatically qualify if they meet the pre-release criteria, which are the same. And they will qualify up to 12 months post-release for ECM. So if for some reason they don't qualify for these services pre-release, they can still access ECM if they meet this criteria in the community. Next slide, please. Okay, so what services are available to individuals when they're incarcerated and they meet that eligibility criteria? So this is the list. This is the summarized list. So it begins with care management. That's at the top of the list. That's going to be the topic of our office hours on Thursday. So I encourage you to join us and we're going to dive more deeply into that subject. There's also a whole long list of physical and behavioral health clinical consultation services. These are services provided to diagnose health conditions, to treat health conditions. So there's a whole bunch of things that fall into that. Labs and radiology are covered. Medications and medication administration are covered. That includes a specific type of medication known as MAT, or medication-assisted treatment. This is for individuals who have substance use disorders. This is a really important aspect of this whole initiative. And then also community health workers. Community health workers are recently became Medi-Cal providers in the community, and they're also going to be accessible to individuals who are incarcerated and eligible for these services. In addition, individuals will be able to walk away with medications in hand. Usually it's going to be a 30-day supply as clinically warranted. And that the idea behind that is that to help individuals get to that next appointment in the community. And if they need any DME, durable medical equipment, such as a walker to get around, they can leave the facility with Medi-Cal covering that equipment and leave the facility with that in hand. Next slide, please. Okay, before I get to the money piece and the reimbursement models and how all those services get paid for, I just want to pause and see if there's any questions. I haven't seen anything in the chat, but are there any questions thus far? I know I'm covering a lot.
Yes, I had a question.
Hi, Arita. Yes, please. Go ahead.
Hi, just really quick. So, You mentioned that if they meet the criteria for pre-release, that automatically puts them in for the population of focus coming from transitioning from incarceration. Does that mean that they would have had to be enrolled in pre-release, or just the fact that they just meet the criteria?
Yeah, so it's a good question. So the way that this is going to work is um, theoretically, an individual, they'll come in, they'll get evaluated, they will be verified to be on Medi-Cal and to be qualified for pre-release services, and then those pre-release services will start. And part of that work is to actually end up connecting an individual. They'll get a pre-release care manager, and then eventually they'll get connected to a post-release ECM provider to continue the care management in the community. Now, the big caveat here is, are they going to be in the correctional facility long enough to have all those connections happen and have all those assignments happen? So assuming they're there long enough, then yes, they will be able to get connected to ECM. But if they're not, Areta, then they would still qualify. If they were incarcerated and they meet those healthcare criteria, if they're an adult, they would still qualify for ECM. So let's say they're only in a facility for 2 days and then they leave. That's enough to qualify under that population of focus, again, if they meet that healthcare criteria. Does that answer your question?
Yes, it does. And then I
Well,
had one more, maybe I'm preempting, but I'll ask.
no, please go ahead.
I was, I was, I think I was told that pre-release, only the jails have access to that function.
So it is the jails, that's correct. Youth detention facilities, and those would be not under the jurisdiction of the sheriff's offices, but under the jurisdiction of probation. And so that could actually, there could be adults, technically speaking, in those facilities, if they're up to, usually it could be like 25, maybe even 26 in some cases. And then the state prison system. So anyone who's coming out of a facility overseen by CDCR, the Department of Corrections and Rehabilitation at the state, is also covered under this. So it's more than just the jails, but there are a couple other types of facilities.
Oh, I'm sorry, Miss Rebecca. No, my question was the ability to enroll somebody in pre-release, that has to be done by the
Okay, I
correctional
see.
facility. Was that
Yes,
correct? Okay,
I
thank
see. Okay, thank you for clarifying. So that is correct. The correctional facility sort of holds the responsibility for verifying an individual's eligibility for pre-release services. And they will actually be reporting that eligibility up to the state using a special portal called the JI Reentry Screening Portal that the state developed in order to do that. So that is correct. It's going to be the onus and responsibilities on the correctional facility to be reporting up to the state. Anyone who's in there, in fact, they have to report up to the state everybody who's incarcerated, and they have to say whether or not that individual qualifies for pre-release services. Great questions, and I encourage you to join us on Thursday. We're going to get into a lot more detail on some of these points as well, Loretta. So thank you for your questions. I know we got to transition shortly to our next speaker, but I want to talk really quickly about the reimbursement models. You're welcome, Loretta. The reimbursement models, because this is a really important piece. If you guys are providing any of these types of services, then you want to get paid, right? Like you got to have a sustainability plan for the long term for your staff and for your patients, right? So there are two pieces here. So on the left-hand side of the screen, I have pre-release or detention when someone's incarcerated. On the right-hand side of the screen, I have post-release when the individual's back in the community. You guys are very familiar by now with the post-release, what's happening in the community. You're very familiar as an ECM or CS provider that in order to provide services, ECM and CS services, you have to establish a contract with a managed care plan, and then you work with the managed care plan to get reimbursed for the services that you provide. This is not the same model that's being used for the pre-release services. Instead, so managed care is going to be on the outside on this one. Instead, when individuals are incarcerated, the state is using a different model. They're using Medi-Cal fee for service. And what that means, it means that the correctional facilities will need to enroll, and any other provider who's providing either on their as an in-reach provider as well, will need to enroll as a Medi-Cal fee for service provider, and they will bill the state directly for the services that are provided. And this may seem like a nuanced detail thing, but it's really important because if you're a provider who's operating on both sides of this equation, before an individual's released and after an individual's released, you need to be able to operate under both of these reimbursement models, which means you need to have managed care plan contracts and you need to have be enrolled as a Medi-Cal provider so you can do fee for service, even if it's just one activity that you're providing before an individual returns to the community. So really important. We're going to get into more of this on Thursday. Next slide, please. Okay, wanted to share this slide from the State Department of Healthcare Services. It just gives you a sense that there are so many players that are involved to make this JI reentry initiative happen, for it actually to get implemented. Of course, correctional facilities are critical. They may have vendors doing a lot of these services. They may bring in reach providers, community-based providers to help them with some of these services. Pharmacies are going to be involved because medications are covered. And on the community side, you have behavioral health agencies, you have social services departments who are involved in the enrollment piece into Medi-Cal. It's a really critical piece. And then managed care plans and all of you ECM providers and even CS providers are also playing a critical role here. So I want to paint the picture that there's a lot of players involved in this whole initiative and a lot of players that need to work together that maybe haven't always worked together to make this implementation successful. Next slide, please. Okay, so I shared the policy, but I want to kind of give you a flavor of what it's going to be like on an individual level. Now, even though I'm going to go through this, I just want to say this is an oversimplification of what this is going to look like because it will really depend on an individual's healthcare status, Medi-Cal status, what facility they are in, and how long, especially how long they are in that facility, what their individual level experience will be to get these services under the JI Reentry Initiative. So it all starts with an individual coming into, entering a facility, getting booked into a facility. Very early on, there's going to be some assessments for their healthcare needs and otherwise that occur, and services in some cases will be provided very quickly. Also, hopefully very quickly, they'll be verified for their Medi-Cal, being on Medi-Cal, and verified that they're eligible for pre-release services, as we talked about earlier. Those services will be provided, and then at some point, typically relative to when they're anticipated to return to the community, there'll be a reentry planning period where a reentry care plan will be developed, which will continue with that individual into the community. That will guide the next step of the handoffs and linkages. This is to help coordinate all of the providers who are engaging both pre-release and post-release with this individual to support their care. And then they'll return to the community, and that's where all the community-based services will switch on as well. Next slide. Okay, so quickly, where we've been, where we are in terms of timeline. January of 23, the mandate went into effect for correctional facilities to support individuals to enroll in Medi-Cal during incarceration, so that's now happening. January of 24, ECM went live statewide for this population of focus. It's technically individuals transitioning from incarceration. I've also been calling them the JI population of focus. And then right now, we are in this window from October of last year to September of 26, a 2-year window for correctional facilities to stand up these services and go live. And so they have the choice of what time within that 2-year window to go live. So I want you all to be aware of that. So there's differing timelines that are happening. And as providers, especially ECM and CS providers, I want you to be aware that all of the requirements related to handing off to you in the community and linking to you in the community are not going to happen until the correctional facilities timeline has launched to go live. So just be aware of that. It can happen at any point during this window. Next slide, please. Okay, I'm going to wrap up here, which is as I understand it, where correctional facilities stand in terms of their status of going live in your region. And I want to point out, you'll have these slides, you can look at the details, but I want to point out that Siskiyou, their adult facility has gone live just earlier this month. So I know everyone's very interested and eager to hear how it's been going. And then back in February, CDCR went live. And that's a big system. This is the state prison system that's gone live, and this is going to impact all the counties because individuals from this, who are in the prison system can return to any county throughout the state. So even though regional or locally or in your county, if there aren't facilities that have gone live, you will see individuals returning from CDCR. So you need to be prepared for that. And some of you ECM providers who are providing services to this population of focus may have already started to get phone calls from CDCR. Okay, I think we're a little behind on time, so I'm going to move us straight into our next speaker. You can go to the next slide, Eva, and just welcome everyone to join us on Thursday. We can talk more about the JI Reentry Initiative together. And I want to introduce our next speaker, Ron Klinger from Partnership Health Plan. Ron is the man in terms of JI at Partnership Health Plan. He's officially the JI Reentry Initiative Liaison. So when it comes to making sure that individuals are getting enrolled into ECM and supported and connected to an ECM provider, Ron and his team are the people behind all of that. So I'm going to turn it to Ron to share with us a little bit about what's been going on regionally with Partnership and MCP. So thanks, Ron.
Thanks, Rebecca. Hi, everybody. So yeah, as Rebecca mentioned, I am your Justice Involved Liaison. I am actually the manager of this program at the health plan. And as the previous slide mentioned, I am in all 24 of our counties. So spread a little bit thin these days, but always here to help. And I will get back to you on your questions as quickly as I possibly can. So the next slide, please. So these next couple of slides, these just are, I'm going to move through them quickly because I'm assuming you can all read these on your own. And I also assume we're going to be sharing these slides out with the group. But this is just a list of our current ECM provider network by county, and you can click through, please. So these are your, you can see some of the larger populated counties have more, providers available. That's pretty normal. But we do have this service available in all 24 of our counties today. So just know that there are places for your folks to go should you have referrals. Now let's talk about Siskiyou, who did go live. So far, it's been a little bit of a soft start, I would say. We haven't seen, I don't think we've actually seen any actual referrals come in yet. We do know that this will grow. And one of the things I'll just mention about this program is that it is going to start growing when we start to have some buzz about it on the street. I'll just kind of put it there kind of bluntly, right? We can do nice little cartoons and videos. We can go in and speak to folks. We can do all of that all day long. But until peers are saying, hey, this ECM stuff worked really good, I liked it, that's where we're going to see the real kind of explosion of this. So as Rebecca mentioned, these services are an opt-in. And then kind of another piece of the answer to Aretta's question earlier is that the pre-release services that were listed in one of Rebecca's slides, the medical, physical, behavioral care, things like that, that doesn't require permission. That's just the facilities are providing this healthcare and behavioral care, and they're able to now bill for it. It's the care coordination and case management piece that requires an opt-in on both sides. So that is something that we are working with our counties with, is to help us identify those that are really engaged and want to do ECM. So just know that as providers, we're doing our best to send you actual hot referrals, not just folks that have been identified as coming out at a certain time. But do know that there may be a little bit of that at the start while everyone gets to know the program. Be patient with us, and I'm certainly happy to hear if you're seeing a pattern of repeatedly trying to engage with folks who just aren't interested, because we want to make sure that we're educating our correctional facilities correctly. Okay, next slide. And so the other piece that I want to let you know about, it's still kind of in development, but we're in the last stages of developing a single template for data sharing. It exists as an Excel spreadsheet in order to make sure that it is something that is accessible to all. And that template will be the means of sharing information from the correctional facilities to the health plan about who we need to assign one of you ECM providers to. So that process has been laid out and developed, but we're just putting the final touches on the data sharing template itself before we roll it out. As counties go live, I will be meeting with them all and talking about our secure file transfer protocol site that we've developed, which is a secure way to upload protected information to us, and vice versa. We can drop things in there for the counties and other providers to hop in and access them there. So that's a secure means of sharing data that we have in development. Next slide, please. Now, as Rebecca mentioned, Medi-Cal enrollment is important for this for this, and there's a little extra nuance or layer to it. Anyone who contracts with Partnership Health Plan also has to be Medi-Cal certified. What's new and specific for those serving the justice involved population in focus is enrollment in this system called PAVE, Provider Application Validation for Enrollment. So what this is this is the billing system essentially that you would use to bill for those bundle rates, those services that are provided before the individual is released from incarceration. So for the warm handoff, for any additional conversations you have with correctional staff about the transition plan and whatnot. Those things are billable directly through the PAVE system. So you'll not only need Medi-Cal certification, you'll also need to be enrolled in the PAVE system to provide for this population. And that is, we have been sending out this information to our known JI providers and those who are interested. It has been taking a bit of time. So just be aware that as you begin your application, this is a state system. They're not always known for being really quick and turning things around. So if you're interested and not yet serving this population, I encourage you to take a look at this website and start the enrollment process as soon as you can. Next slide. And I think that's it. Did we want to go over care planning briefly here? I remember originally there was some talk about showing a few things. I can just show you a couple of quick slides. Care planning for me as a case manager and an old-time pediatric nurse is a deep topic that would take me hours to really unpack. So I just picked a couple of things. One is this chart that you hear us using the use of SMART goals. And I've also included some links later on the slides that you can use to get a template and a little more of a description of what SMART goals are. But goal setting is really the meat and potatoes, if you will, of a good care plan. It's the ongoing work. It's here's what we want to accomplish. Here's when we want to accomplish it by. Is it something we can really do? Is this something that the person is interested in, or is it just something that you as a care manager are pushing on them? And then always time bound, right? We need to make them time bound so that we know when it's time to renew them or start over or refresh or modify the goals, right? Okay, so to keep it, I know we're short on time. I'm going to go to the next slide, please. So again, just a couple of helpful tips. Again, I can go on for hours about this, but this is just thinking about what the goals are for. They keep us on track. They let us know if we're successful or not. That's why you have to have that time limit on it. Otherwise, it could just stay open forever and you're not learning from it. You don't get the opportunity to recognize, oh, we didn't meet this goal as we expected. What were the barriers? What do we want to change, right? Another important basic thing with care planning, when you're filling out a care plan document of any sort, whether it's the one that partnership provides or another one, don't leave any section blank, right? We are auditing our providers for quality, right? We're required to do that by the state. We're looking at the care plans, and if you leave something blank, if I'm the nurse reviewing it, I just have to assume you never asked that question. But if you tell me why, maybe we weren't comfortable talking about an advanced directive today. Totally understandable, but put a little note in there that says that. Now I would know you attempted the conversation, it didn't seem appropriate, and so you moved along, right? Another important thing, let's say you do a PHQ-9, a depression screening, and they get a really high score, like a 22 or higher. There should be something in the care plan of what you're going to do about that, right? You don't want to record blood pressures way out of whack or some significant unmet need, and then there's nothing further down in the care plan that addresses that. That way, you're just saying there's a problem, but you're indicating that you're just ignoring the problem, essentially, right? So if you keep that in mind, you have to keep things filled out, even if it's not applicable, or a little story about, oh, he wasn't, person was too tired. We'll continue asking some more questions at another meeting, something like that, just so we know what's going on. And then not responding. And then I just want to lastly point out that we are looking at a date in June for another care plan training that we'll be providing. I'll probably be involved in that on some level as well, but there is training available from the plan on the skill set needed to do this work. Okay, that was about as fast as I can talk about care planning. So the next slide that I think Eve already put up, just as you'll get these links. These are just some useful things in terms of thinking about how to have these conversations and whatnot. More information about some of the topics here would be in our larger care plan training that is upcoming. I don't know if we have time for questions, but I'm happy to entertain any if anyone has them.
Yeah, we definitely have a few minutes if anyone has questions for Rebecca or Ron.
I actually have a question. It's pertaining to people that have been incarcerated and they've gone through the transitional housing, trying to get into permanent housing. I'm finding out that they have, if they're felons, um, they have to wait 10 years before they could get housing in apartments.
So that's per the landlord, honestly. I mean,
Yes.
there are significant challenges with this population. Nobody should have any illusions about that, right? And the various things that are offered under community supports, none of them is an ongoing long-term type of solution, right? Unfortunately, the way the state defined these is that they are limited in scope, limited in time, and even some oftentimes limited in number of times it can be available to the same individual per lifetime. So community supports, let's not kid ourselves. It's a way to kind of bridge the gap to buy us some time to get something more permanent in place. But that is going to require some strong advocacy in many cases, Lori. And the problem of shortage of actual available housing in general causes landlords to be able to be a little more picky about it and things like that. So without further legal reforms, this is going to remain a challenge. I'm just trying to be honest about it. We can't manifest a house for somebody, but we certainly can do our best to make the point and argue as best we can.
I was just hoping you had some leads.
If you want to reach out for specific areas, we might, but honestly, this is a problem everywhere, especially as you know, up in our more rural areas, right? There's just not inventory out there available. I will say, partnership is investigating some opportunities to possibly um, purchase some real estate and actually help provide some of this. This is above and beyond the managed care's duty, but it's kind of how we like to roll. So more to come on that. I can't promise anything today, but I know that we are looking at some of those options today.
That would be nice. Yeah, because it is a challenge.
It is. And of course, if we do something like that, it'll fill up right away and we'll be right back there. But at least it's a few more people that we can provide a roof for. It's a challenge in our state, maybe even more so than a lot of other parts of the country, but it is a challenge everywhere, just finding housing in general.
Lori, would you be willing to share a little bit more? It sounded like you were that you're actually providing ECM services to formerly incarcerated individuals. Is that for somebody who had already been in the community, or were you providing sort of pre-release support with housing as well?
Well, I've had a couple of patients that we've had go into transitional housing. It just so happens that they had prior convictions. And then it came up when we were getting them into permanent housing that, they had prior convictions, and we're like, oh, okay, well, there's we got another hurdle to go over. And they were told to um, find a friend to room with and have them do the application and then house with them to try to do a workaround. So yeah, we're trying, it's some of these have been challenges.
Yeah.
Yeah. I'm
Certainly
happy to talk
complex.
about those more individually with you, Lori, if you want, and see if we can come up with something. But yeah, far from the first time I've heard about that challenge. You also bring up an interesting point, if I can quickly make it. The eligibility for the justice involved population of focus is for anyone who has a 12 months or less um time, how do I say this, who has been incarcerated in 12 months ago or less. So what that also means is that after 12 months of being released from jail or prison or detention, they're no longer technically eligible for that population of focus. But what we know is that they're always eligible for another one, right? So don't get locked down on that. When you're filling out your care plans and when you're sending information to us, check every population they can qualify for. That way, when you hit that 12-month mark, you just uncheck JI and keep working, right? So it's something to keep in mind.
And it's hard too, because with it's it's really hard because the transitional housing, it is so good for some of these patients because, they're getting out of the recovery, then they're getting in the transitional housing. They're finally getting work for the first time in God knows how long. They're doing good. And then they're right in the process of getting kicked out of transitional housing when they really should be staying
Yeah.
because they're just getting back on their feet to where they can get into permanent housing. It's like you're almost kicking them right back on the street when we should really be wrapping our arms around them still because they're right there.
Yeah,
It's
absolutely. Yeah.
that's what I'm seeing.
So in the hospital, we say discharge planning starts when someone is first admitted to the hospital, right? For transitional housing, looking for permanent housing starts as soon as they start transitional housing. I'm not suggesting that you didn't do that, because even if you do, it's still a problem. But just something to keep in mind is that we should not be waiting. We should be right away trying to look so that we have time to explain the situation to the landlords or ask for special consideration if they have a particular requirement, things like that. Because that time comes up quick. It'll always be here sooner than you think.
Well, when you talk with the behavioral health department, when you got somebody going into Empire recovery, they're saying, oh, it's going to take this patient with their drug use at least a year to get their mind right before they could even think about getting a job. Well, then you got your whole 90-day Empire stay, and then you got your 6-month transitional. Well, you're not even at your year yet. So we're still not there. That's what I'm saying.
Uh-huh.
It's taking that whole time to get that person right, to get where they need to be.
Yep, absolutely.
Yeah, this is a really important conversation. And thank you, Rebecca and Ron, for being so available to have these conversations with everyone. I did just drop the link for the office hours that we're going to be having on Thursday, where we'll continue a lot of these conversations. So please register for those office hours, but then also reach out to us individually. Let us know how we can support you on a case-by-case basis as well. I'm just going to move us forward because we only have a couple of minutes left. But that was such an information packed section. And thank you both so much for being here and for sharing all of that. I just want to provide some information about our May in-person session. We will be holding it at Shasta Community Health Center in Reading again on May 20th from 11 to 2. I'm going to put the registration link here in the chat. We would love to hear from you all about what you'd like to see on the agenda and if you'll be able to attend. And one of the things that we're thinking about including on the agenda for our in-person session, is to engage in a scenario planning activity. So I'd also just love to get a sense from everyone here if that's something that sounds interesting. And this is also sort of related to this question here about we're just wondering, we're hearing a lot of different things. There are a lot of things happening in the landscape, and just wondering if your organization is being impacted by any of the recent federal and statewide funding cuts. So feel free to add anything in the chat or come off mute. But the idea for the scenario planning activity would just be to sort of, think about some potential situations and how to navigate those. So I'll just pause right there. I know we only have a minute, but would love to hear, if your organization is being impacted by the cuts and if you'd be interested in that activity as part of the in-person session. Okay, so I heard from Loretta and Caitlin. If anyone else has anything to share, please put it in the chat or feel free to follow up with me via email after the session as well. Okay, thanks, Megan. Yeah, so please fill out that registration form. It'll help us make sure that everything that's included in the agenda is really responsive to what you all would like to see included. I know we had a really great session last time, so would love to continue that. Okay, thanks, Toby. Okay, great. So yeah, again, please sign up for office hours on Thursday, where we'll be continuing a lot of the Justice involved reentry initiative conversations and talking a little bit more about care management. Just to note that that is a joint office hours with the San Joaquin and Stanislaus Collaborative. So if you go to the link and it says San Joaquin and Stanislaus, you're not in the wrong place. It's just a joint office hours. And then as always, please always feel free to reach out to us for individual one-on-ones. And thank you all so much for attending today and for your engagement. Have a great rest of your week, and we'll see you soon.